Hello, everyone. So, welcome back to the We Go Beyond podcast. So, this is episode number three. We have a very special guest on this week, Jake Doleschal. So, I've been mentored by Jake for the past 10 months, I think. And I've followed Jake for maybe the past 2 years. Jake is an absolute expert in all things health and fitness, including training as well. So, in this podcast, we're going to be diving deep into more gut health and health base handbrake, should we say, for the general population. And we're going to be diving more into training modalities around beginner and intermediate trainees. So, without further ado, welcome, Jake.
Thank
And
you for having me. It's a pleasure to be here.
cool. So, if you want to just maybe give the listeners a bit of a background on yourself, mate, for those who may not know you, even though they should.
Yeah, so I'll be quick here because when I listen to podcasts, I normally skip this bit. So I'll try to keep it nice and concise.
Yeah, cool.
So basically, I kind of started out in this field as a strength coach. And really early on, I started seeing that I was getting a stack of clients who weren't getting the results they should. And at the same time, I had family and loved ones who also were struggling to get the kind of body composition results they should have been getting. They were working with amazing coaches, some of the best that I knew of, and they just weren't getting anywhere. And so it didn't take me long to realize, you know what, there's some other stuff going on from a health perspective that is actually stopping some of these people from seeing the body comp results that they want. And that led me down a path, a pathway of blood work and lab work and diving into more functional health. I was really lucky at the time that one of my mentors, a guy named Dave O'Brien, I just happened to stumble across him, and I've been mentored with him or by him for, God, I don't know, getting close to 10 years now. But it led me down this path of ultimately how do we integrate functional health and blood work and, you know, whatever else is going on from a digestive standpoint, and use that in combination with training and fitness to actually achieve not just better health, but also better body comp, better fitness. Like as a overall human, how do we get this person functioning better? So that's kind of how I started, what path I went down. And I guess it's evolved a little bit over the years. Like for a little while, I went kind of really heavy down that. And then I started, most of my clients were coming to me with autoimmune conditions and I guess ultimately health conditions that they've just been let down by the conventional medical system with. And then now it's kind of swung back a little bit to people who have the combination of, you know, wanting to achieve a better physique, but still have some of these, whatever the underlying health issues might be, and how we can kind of address both of those things simultaneously.
Cool. I mean, obviously, I've been mentored by you over the last 10 months, and the reason is similar why I came to you is
Mm,
because we're seeing a lot of different general population people not being able to progress, but yet doing everything right in
yep.
inverted commas. And when we dive more into blood work and different health handbrakes, that's when we see where the actual root causes are. So, yeah, pretty cool.
Mm.
So obviously we discussed this before. Obviously we weren't live, but for those of you maybe be just tuning in for the first part, this is your first time watching us. What me and Dylan normally do is just ask the guests a few questions each. So we'll kick off. I'll go with the first question. So my first question, Jake, is for the listener, why would you advise everybody gets private blood work done, and why?
Yeah, so I feel like I'm spoiled. When I get a client, I always have blood work. And there's a few times I'll get clients where I don't have blood work. And I'm like, holy crap, how do I do this again? Like I used to, it blows my mind that I used to coach people not having that information back in the day. Because ultimately what it tells us is it tells us exactly where you're at this point in time. So I'm not against other lab work or, you know, DNA testing. That stuff has value to it. But when we do blood work, we can see at this point, you know, we need to acknowledge that this stuff is transitory, right? So if someone did something silly beforehand, they had a bender, you know, they were sick, whatever, obviously that's going to be influenced. But if we take those sort of outliers away, when we get lab work, we're seeing at this point in time, does your body think that there's an infection going on? Is the inflammation going on? And I don't mean an infection like the flu. I mean some kind of like subclinical infection that people don't even, you know, haven't put their finger on. Like they just feel bad. You know, their energy is just low. They have joint pain, whatever. This sort of underlying cause of inflammation in the body. So it'll tell us, is that going on? It'll tell us what are the basic nutrient deficiencies that might be there. We're not seeing all nutrients, but we'll get an idea about B vitamins and zinc and iron, and we'll get an idea about, like even, early stages of anemia, by the time someone's like classified as anemic, that's so far down the line. Like that person's been experiencing symptoms for months before then. So we'll get a chance to intervene early, right? So initially when I get a client coming to me, it's telling me what's your nutrient status. It's telling me what's your immune status, your inflammation status. It's telling me, is there any sort of like, I guess, metabolic or underlying kind of burden that's kind of ticking away that we want to jump onto now. And, it's not normally going to be, depending on the client, but it's not usually going to be something too sinister, but it's enough that we can actually intervene now before it becomes an issue, right? If we look at the stats of chronic health conditions, we know that 30 to 50% of people have a chronic health condition. And this is an opportunity to, for that 50% of people who don't, like, well, maybe we can actually, stave that off longer if we actually intervene early. So from a health fitness perspective, absolutely, it helps us as coaches. But just from a general perspective, in terms of getting the general societal health better, it just helps us intervene early.
Real makes sense. And like with blood work, just to add on to that question, mate, what can you explain to the listener about like conventional versus functional ranges?
Yeah, absolutely. Because people often think, well, hang on, I got my bloods done. The doctor said it was all good. So clearly I don't need to do this. And there's a time and place for conventional medicine. I'm certainly not saying that there isn't, but we need to understand when we look at lab work from a conventional standpoint. So the doctor's done a blood test and they said, hey, we think that, these are the values it should be. Potassium should be, I don't even know the conventional values off the top of my head, 3.5 to 5.0, whatever it might be. The way that they ascertain those numbers is two different ways they do it. Some of them, they have a target. Not many markers are like this. So this is where there's been some kind of like convention and they said, okay, cholesterol is a good example. We think everyone should be here. And then they set like this global standard for everyone. Not many markers are like that. Generally, what's happening is the lab is ascertaining or determining those values. So someone goes to a pathology or they go to a lab, and the lab is just going to collate all the data they get from everyone who got a blood test, right? So these are generally going to be older people, sick people, like people getting bloods done at the doctors. And it's not even long-term data. They might do this over 12 weeks, or they might do this over a year. They might do it over, I've even heard of some labs who literally just tested their employees, right? Like they didn't even collect data from the patients. And then they aggregate the data and then they plot it out. And if you fall within that 98th percentile, then that's normal. That's conventional values. And, the issue with that is obviously, we're looking at ultimately a sick population, but you can have someone who has a diagnosed health condition and they're not excluded from that data. At best, they're going to be excluded from the data that is completely relevant, like the marker completely relevant to that condition. So say you've got a type 2 diabetic, they may not use their glucose test result for that data, but they're going to use their cholesterol data and they're going to use their white blood cells and their liver enzymes. So you're literally comparing yourself to people who have diagnosed medical conditions. And as long as you're kind of fairly normal compared to that, then that's what you're being marked against. So what we try to do, and people assume, oh, okay, so what's the alternative to that? Functional blood values or optimal blood values, whatever you want to call it. And people assume that this is just easy to find in a research paper, but it's not. You can't just pick up a textbook and look at, oh, well, these are the optimal values for blood markers. It doesn't exist. So ultimately, and this is why there's a lot of debate over this, because what we do is we look at the studies and research and say, well, what if we've got available to us? Here's a study where cholesterol is a good example. We've got studies that have been done by like insurance companies, and they want to know, they've got a vested interest in knowing, well, when are people likely to die? Like, how does this blood marker correlate to death? Because that's going to help them with payouts. Yeah. And so we can look at studies where they've tested, for example, 12.8 million people over more than a decade. And we can see at what stage are you more likely to die? And that's, like, I know that death or avoiding death isn't optimal health, but it's a pretty good starting point, right? Because we can actually look at conventional values and say, well, in that conventional value, you've got a twofold higher chance of death. Like that's not a good starting point. So that's where I begin with when it comes to functional values is, do we have data on what's going to avoid me dying? And then we can take it a step further and see, well, do we have other data on health conditions? So, what values are associated with cardiovascular disease or associated with, metabolic disease or whatever it might be. And then we kind of piece that together. And so it's not straightforward. And this is why, you've probably noticed, Nate, like in the time we've been working together, there's probably been some values that we've changed, right? There's been some where maybe, 0.1 or 0.2, because as data comes out, we're like, oh, we've got better research now. Okay, maybe we were slightly off there. Maybe, for an example might be liver enzymes. I've shifted my optimal values for liver enzymes by a couple of points over the last couple of years. So maybe we thought it used to be 10 to 25, and now we think maybe it's, 12 to 22. It just shifts a little bit as we get more data. So I guess that's a long-winded way of answering the difference between those two.
Yeah, so it's basically we're not trying to compare ourselves to the general population that is potentially in ill health. We want to compare ourselves to like maybe more of an optimal human being, should we say? That's maybe I always explain this, Jake, in a way of like we're trying to prevent disease before disease happens.
Yeah.
With the functional range as opposed to like a conventional range, which is a heck of a lot wider, should we say?
Yeah. And the funny thing here is sometimes you'll even see, like a good example here would be like creatinine. This is probably the best example I can think of, where creatinine is a good reflection. Ultimately, it's a proxy of muscle mass, right? Obviously, other things can affect their kidney function, but the more muscle mass someone has, the higher their creatinine level is going to be. And in sort of the values I work off, I would work with about 60 to 100, give or take, is optimal values there. And in conventional values, depending on the lab you go to, I've actually seen that shift down and down and down to the point that some labs are now working off something like 40 to 60. And so I've had people who are borderline on the low end of what I would say is optimal, and the lab has actually flagged them as elevated, as too high. And it's just mind blowing. Like you can actually be like, there's not even a crossover with these values sometimes, purely because of people obviously getting tested there, under muscled, probably underactive, sedentary. And you see this as well. Actually, this is a big issue in labs where there's large, like vegetarian populations. So the data actually for those labs over there, things like B12 status, if you look at those values, they're a lot lower than what they should be because they're testing a population that are essentially B12 deficient. So sometimes the optimal values aren't even in the conventional value, like they're outside of that completely.
And that's kind of where the medical realm is heading as well, isn't it? With a lot of these different values, where it's kind of confusing people a lot, which then we kind of, in a way, not go against them, but like we challenge them, and then it's hard to get some people to kind of trust what we kind of say in a way, if that makes sense, mate.
Absolutely. I mean, because the thing is with blood work is like, who's a specialist in blood work? Like, is your GP a specialist, your doctor? Not really. Like I've mentored doctors in blood work and they have acknowledged to me that they don't really know anything about it. I've gone to doctors and asked them about markers and they've said stuff, oh, God, I don't really know what that marker is. I've had clients tell me their doctor Googled a marker in front of them to see what it was. Yeah. So a GP is not a specialist, but then we're health coaches or nutritional therapists or whatever we are. Like, we're not specialists. Like that's not part of our curriculum of what we study. Obviously, we can go down that pathway externally, but no one's actually a specialist in this area. So who do you listen to? It is a bit of a weird area.
Yeah. Cool, mate. That was fab. Dylan, what's your question, mate?
Yeah, so more down the training avenue, mate. Do you believe in a training split that allows for constant progression without the need for a deload?
Without the need for deload, yeah, I think so. If people are listening, like, hang on, what's a deload? So obviously, there's different ways of doing a deload, and usually we're going to talk about reducing intensity or reducing volume for deload. So something is going down, and the idea, in a nutshell, is you've accumulated this sort of, whether that's, I would say, fatigue, or you've accumulated damage or whatever over that period of time. And then we're saying, well, let's reduce that stimulus or the volume or whatever, so we can kind of get this extra recovery and these extra gains occurring over that week or whatever. So I would say that if we look at muscle physiology, we know that a muscle's not going to continue to grow 2 weeks from now. Like, you can't go in the gym, do 100 sets, sit back and do nothing for 2 weeks, and 2 weeks later we're still stimulating MPS, like muscle synthesis, right? Like, that's just not going to happen. So if we look at a deload from that perspective, it simply cannot be helping us get bigger, building more muscle in that amount of time. So the purpose of that can't be to build muscle. So what's the purpose? The purpose is to allow us to continue to progress. So if someone's plateaued and they're not progressing anymore, I would suggest, and I don't know if we'll talk more about this, but I would suggest that means ultimately they're not managing their fatigue. And fatigue isn't psychological fatigue necessarily. It doesn't mean that they're going to the gym feeling tired. It's not a feeling, okay? Fatigue, there's different mechanisms here, but it's our ability to use muscles and muscle fibers. So if someone's got to a point where they've overdone it so much with the volume they're doing in the gym or whatever, intensity, and they've got to a point where they're not progressing, they're not adding weight to the bar, they're not able to make any changes or adaptations, that's where they need to do a deload. So they've actually got time now to recover because they're not recovering between the sessions. So I would say that ultimately the best thing we can do is try to program in a way that you don't need a deload. A deload, I don't know if I can swear on this podcast. Can I swear?
Yeah,
go for it.
So a deload is literally like an oh shit button. It's like, I didn't manage this. Shit, I need a pause. And so sometimes you're going to use that. And as coaches, sometimes I use that sometimes. But it means that we kind of stuffed up a little bit. We gave someone more than they were capable of doing. So it's a tool that we don't want to have to use, but occasionally we have to. But, to program it like proactively makes no sense to me. I can't fathom why you would do that.
Yeah, I think I've had a couple of clients or a couple of people in the gym who they train loads and then they'll be saying, oh, I'm on my second session today. I feel like they overtrain and then they'll just be like, oh, I'm just deloading this week. Do you know what I mean? But where they don't realize they've just ran themselves into a wall. And like you said, they've not managed their own recovery.
Yeah.
They're not focused on sleep, nutrition, or anything, to be honest.
Yeah. And I don't know if you've seen this happen, but there's been a trend I feel like I've seen where people are now calling things a deload that's actually even more fatiguing and more damaging. So they'll go from doing their standard, maybe they're doing their 5x5 system or whatever. It's like, oh, I need a deload. I'm going to go to high rep work because it's not going to tax my CNS, my central nervous system. And they start doing, sets of 15 for the week. And it's like, well, hold up. That's actually more taxing for your central nervous system. So it's like, if you're going to deload, at least deload. But we're almost doing it like just making this problem even worse nowadays.
Yeah, I think that's a good point as well. During said about the central nervous system for like the general population listener, like how lifting weights does fatigue your central nervous system. It's not just your muscle that's being fatigued. Could you explain a little bit more on that?
Yeah, absolutely. So I think managing fatigue, I honestly believe managing fatigue is the number one most important thing for someone to continue to progress in the gym, especially from a muscle hypertrophy standpoint. So we've got two main types of broad sort of categories of fatigue. You've got the muscle fatigue, which is called peripheral fatigue. And then you've got CNS fatigue, central nervous system fatigue. And there's sort of two different ways of looking at CNS fatigue. There's like brain-based CNS fatigue and there's spinal CNS fatigue. Now, long story short, if we accumulate fatigue in the muscle, that's not that big of a deal. Like you will feel that in the session, but that in and of itself isn't going to really impact us for that long, right? CNS fatigue, I mentioned there's two types there. One of those types is going to impact us within the session. So basically, in a nutshell, the more we do work, the more we contract a muscle, the more that elevates one of these types of fatigue. And so it increases what's called perception of effort. And so our body is trying to be protective. Our brain is being protective. And it's saying, well, hang on, you're doing a lot here. I kind of don't want you to run out of fuel and I don't want you to damage yourself. So what it's going to do is increase that perception of effort. And that's going to cause a down regulation in our ability to use muscle fibers. So that accumulates, it builds up over that session. So you do a 60-minute session, you do, let's say, 10 different exercises in that 60-minute session. This is why that last exercise you're probably progressing worse on than the first exercise, because that's just building up. But then we've got this other type of scene, and that's like, we need to be conscious of that, but it's not that big a deal because you come in the next day and you're good to go. But the other type of CNS fatigue, that actually lasts longer. And so that's a little bit more to do with like muscle damage, inflammation. And when that occurs, until that is totally cleared out, that's actually going to cause a down regulation in our ability to use muscle fibers as long as that's there. So we see this in studies that they'll test like maximal isometric contraction, sort of voluntary contraction. So basically they'll test how much of your muscle can you use. And then they'll see that, let's say a day later, there might be a 10% reduction or whatever it might be, depending on what you did. So that's CNS fatigue. It's not fatigue you're feeling. That's the CNS fatigue we want to be concerned about, at least. It's not what you're feeling, but it's where your body, your brain is actually stopping you from using those muscle fibers, which you're not even going to notice, but it's going to stop you from using the muscle fibers that you actually want to use that are going to hypertrophy. So you're just not going to get the results you want.
Yeah. No, perfect.
So just going back to deloads, Jay, just for the listener. So like, how would the listener know if they need a deload? Like, obviously, if they're a beginner, we could probably dictate that they're not going to need one for a while. But say they're like more an intermediate or like a bit more of an advanced trainer, then how would they know if they need the deload?
So I think we're really lucky that there's a super simple way we can track this stuff. And it's simply using a logbook or using notes on your phone and recording the weight that you're lifting. And if you're progressing, if you're adding weight to the lift for the same amount of repetitions, or you're adding repetitions for the same amount of weight, and your form's not being compromised or whatever else, like if you're continuing to lift in the same manner, that is telling us there has to be some changes that have occurred. You're not just getting, as a beginner, you'll get better just because you're getting better, right? Like you've never squatted before. You walk back in tomorrow and you're going to be stronger because you now know how to squat a little bit better. And next week, you know how to squat a little bit better again. But once you're an intermediate, you're past that coordination stage, unless it's a totally new exercise, right? So if you're not getting more coordinated, why are you getting better? Why are you getting stronger? There has to be an adaptation that's occurred, which is usually going to be an increase in, I guess, what we would call contractile protein. So basically, literally part of the muscle fiber is getting bigger, right? So if that is happening, I'm not really worried about it. Like, you don't need to be worried, because that's telling us that there's enough recovery that's occurring. You're able to recruit more muscle fibers again the next day or next session, that you're still able to adapt. But if you now plateau and you go in and you can't lift any more than you did last session, you go in the next session, you can't lift anymore. Maybe you go in another session, you're actually lifting less than you were lifting. That's telling us that you're not recovered. Like either you're not sleeping well and you're going in and you're unmotivated, and there's other sort of things going on. But if there's nothing else you can put your finger on, ultimately what that's telling us is there's still fatigue present, which is stopping you from using those motor units, which are controlling muscle fibers. So that is when I would say we need to troubleshoot what's happening there. If you're not getting better, let's troubleshoot. And the easiest thing to troubleshoot there is give it longer. Yeah, give it 5 days or give it 7 days, and then go back, do the same thing you were doing, and see if you're progressing now. And if you do progress after coming back after 5 days or a week or whatever it was, that tells us it was just a fatigue issue. You were doing too much volume, you weren't recovering. If you come back and you're still not progressing, okay, maybe you don't need a deload per se. Maybe we now need to look at, maybe you're trying to progress, quicker than the adaptations can keep up with. Maybe we need to look at how do we progress in a slower, more maintainable way. Maybe you're getting a little bit more advanced now. Maybe there's other exercises that complement part of that muscle or muscle region that you're not training, whatever it might be. But the first step would simply be, let's take a few days off. See if you get better. If you did get better, it was a volume issue or a recovery issue.
Cool. Sick. So mate, like linking to training volume to a certain degree. So my next question is, so someone with potential IBS, intestinal permeability, some form of gut dysfunction, like I remember you talking to me about this when we was mentoring, which I thought it was really cool and everybody could take value from. So somebody with some form of gut issue, maybe IBS, intestinal permeability, how would that affect their training, and how would you potentially modulate their training volume based around this, and why? What's the reasoning for that?
Yeah. So I mentioned the CNS fatigue aspect before, and I sort of alluded to part of that as being caused by inflammation. So we damage the muscle, we cause muscle damage, and then things leach out of the muscle that cause inflammation. So things like interleukin-6, for example, will be elevated. Now, so as long as there's that elevation in the interleukin-6 and some of these other inflammatory cytokines, that's going to cause a downregulation in our ability to use our muscles. Now, there's other things that cause an elevation in these same inflammatory molecules. So, for example, if we look at someone with IBS, which is obviously not it's a group of symptoms, and there's different things that can cause IBS, but arguably the number one cause of IBS is a bacterial overgrowth, which I guess we could call SIBO, a small intestinal bacterial overgrowth. And if we look at SIBO, we can see that the most common bacteria that causes SIBO are things like E. coli, Klebsiella, Pseudomonas. Why I mention that is these types of bacteria all produce a toxin called lipopolysaccharides. I know this is getting a bit confusing, but I'm going to bring it back. So lipopolysaccharides, we could call it LPS for short. LPS will directly cause an elevation in interleukin-6. So now the point I'm making is someone who has these gut issues has a higher baseline level of these inflammatory molecules, interleukin-6, in their bloodstream anyway. How do we think they're going to respond if we now do excessive muscle damage type training, which is causing an extra elevation in interleukin-6, which we know in the first place will reduce motor unit recruitment? We know that that's going to be an issue anyway, but this person's bucket is half full to begin with. So that person now, whether they're going to take longer to recover, arguably yes, because there's going to be high levels of baseline inflammatory molecules there, but that's now the main concern. We could argue that potentially there could be a nutrient issue here as well. It's a little bit hard to determine how much that's playing into it, but the best way to determine things like SIBO is actually to look at nutritional deficiencies, unexplained nutritional deficiencies, and especially things like B12 will heavily be affected. And that's partly because the bacteria is competing for that vitamin. But there tends to be other deficiencies as well. Amino acids tend to be affected, and some fats are going to be affected. So you could potentially argue there may actually be potentially a slower rate of recovery just due to some nutritional deficiencies and higher need there as well. A little bit hard to say for sure about that one. So for me, I would look at it and say, well, if we know that there's a higher baseline level of inflammation, and we know that that's going to cause increased perception of effort, and it's going to cause higher levels of fatigue, and it's going to cause reduction in muscle fiber recruitment. Well, we probably don't want to add to that. So let's not do the stuff that adds to that. So then we need to ask, well, what does add to that? What causes more muscle damage in terms of a training plan? And largely, we could sort of divide it up into very high amounts of volume. The more volume we do, the more muscle damage will incur. That's especially high repetition sets. It's more so repetitions than sets per se when we're talking about sort of damaging volume there. And then it's going to be the proximity to failure. So if we combine those two things, we're talking a high repetition set taking close to failure. So let's say instead of 20 to failure, doing so with shorter rest periods will exacerbate that. And doing certain exercises where there's more what you would call passive tension, which is basically the muscles being stretched. So the worst thing we could do, depending on how we're looking at it, but if we wanted to cause the most amount of muscle damage we could, we would do very high volume, very high repetition sets with short rest periods in exercises where we're lengthening that muscle as much as we can, and we're taking it to failure repeatedly. So that is the number one thing I don't want to do with those clients. So if we were just to flip that, what does the opposite of that look like? Well, it would look like, I mentioned high repetition sets will cause more muscle damage. There's probably a bit of a tipping point, maybe around that 8 repetition mark. It depends a little bit, but somewhere there. So we could say, well, we'll probably stick to 8 repetitions or less. We said that short rest periods are going to be counterproductive there. So let's do longer rest periods. Let's do at least 2.5 minutes minimum. And then we said these lengthened muscle positions are going to cause some issues. So either we can drop them out completely, or what I would prefer to do is mostly focus on more mid and shortened position exercises. And then maybe one day a week, we might chuck in some of those lengthened exercises. Maybe we put them all on the same day, and then we give the person 2 days off after that session because there's going to be more recovery demand from that. So these are pretty easy changes. Yeah, maybe it sounds a little bit complicated, but it's really not that much. Like we're just changing repetition sets and the exercises we're using. And the best thing about all of that is what I've just said there. That's not that different to what I think the best training plan someone could follow anyway would be. So we're not even saying you need to do this thing that's not that good for gains, but it's going to help you not cause more muscle damage. We're saying, actually, you know what? This thing that is probably the best and most intelligent way you could train anyway. You just so happen to need to train like that because you don't have this kind of margin for error that other people have.
Cool. Yeah. Amazing. So with that person as well, Jake, you said about flipping the reps, flipping the intensity, etc. In terms of like a training split and like rest days and versus the amount of time they lift in a week, what would you advise for this type of person?
So there's not like a right or wrong answer here, but I think broadly speaking, we would be safer to say have a day off between sessions. Like that, if I was giving generalized advice, I'd say that's a nice way that we probably can't go too wrong. If we stick to those other recommendations I made and you're having a day off between each session, 95+% of people are going to be okay with that. Does that mean they can't do it? So if we're doing that, that means you're only doing 3, maximum 4 sessions every second week. So we're not doing a high, I guess high frequency type training. So in that instance, what kind of split would be best? Well, I'd say really the only 2 viable options would be either whole body or an upper lower split. Like we probably don't want to be training a muscle less frequently than that. So, a full body every second day, I think that makes a lot of sense. But if someone wanted to do upper lower, again, we can, but we have to acknowledge that in that instance, that means it's going to be a higher amount of volume for each individual muscle group because obviously they're going to do half the body on one day and they're still going to do probably the same amount of workload. So there's going to be twice the amount of sets for those muscles that they are training. So they're likely to cause a little bit more muscle damage. So arguably, I'd say a full body split would make a little bit more sense, but there's always a little bit of variance or individual variability there.
Cool, amazing, that. Sweet.
Yeah, I think what you was talking about reps as well, higher rep ranges. I get a lot of people in the gym say about how they don't feel like they can grow as much muscle if they're doing higher reps, let's say 10 to 15 rep range. Do you think you can still build muscle, obviously to like the beginner listener, with a higher rep range, the same as a lower rep range?
So I think there's a few things in that answer. Firstly, I'd say if we look at the literature as a whole, the best way that we can make sense of it, in my opinion, if we look at all the hypertrophy studies and what they find, I think the only way that makes sense to me to synthesize it all is to use what's called the effective reps model. Sometimes people call it the maximally stimulated reps model. So these are models that were put out by Chris Beardsley and then also a guy named Borgie. I don't know if I'm saying his name right. But basically they propose that if you look at a set taken to failure, regardless of whether it's 5 repetitions or 30 repetitions, there seems to be somewhere in the realms of about 5 repetitions in that set, the last 5 repetitions to failure, that seem to be stimulating the bulk of hypertrophy. And if you look at all the studies on, whether a group did 5 repetitions or 6 repetitions or 12 or 30, that seems to be the model that makes the most sense. And arguably you could say it's probably due to essentially we need 2 things ultimately for hypertrophy to occur. We need motor unit recruitment. We're not going to grow a muscle or a muscle fiber that's not being used, but we also need to develop enough tension or experience enough tension in that muscle fiber. And so we could use all the muscle fibers available to us if we did something very like speed centric. So let's say you did a vertical jump. You didn't have any weight on you. You just jumped as high as you could. You're going to use probably as much of your motor units and muscle fibers in your legs and your quads as you can, but you're not going to get jacked doing that. So not only do we need motor unit recruitment, we actually need to have enough tension in those muscle fibers. And to develop enough tension, ironically or paradoxically, we actually need a slow contraction speed. So a fast contraction speed will cause motor unit recruitment, but when we're contracting slow, it allows what's called cross bridging, basically these binding sites in the muscle to form, and that's where we're creating this tension. So what we need is this sweet spot where you're trying to move fast, but you can only move slow. So that's called the force velocity relationship if people want to look into it more. But that seems to occur in that sort of last 5 repetitions-ish of a set. So yes, someone could certainly do the high repetition sets and in the right circumstances and conditions get similar hypertrophy results, not strength results, but they could get similar hypertrophy results. But my argument as to why I think that's inferior, apart from the muscle damage and everything else we talked about, is take I mean, take anyone in the gym, but especially a beginner, and put them on a safe machine, say something like a pendulum squat or a hack squat or something that's challenging like that, and say, okay, we're going to do a set of 15 and stop when you think you can't do anymore. And they do that set of 15. Like, that sucks. A set of 15 pendulum squat, like, goodness, who wants to do that? And they get to that set of 15, they stop. And I wonder if you put a gun to the head and said, you have to keep going. You can't stop. You got to keep going. I wonder how many more repetitions they get. Even myself, if I had to do a set of 15 on a pendulum, gun to my head, I could probably get another 5 out. Like, no one is taking a pendulum. It sucks taking a machine like that to failure. And so if that's the case, if we're giving someone sets of 15 and they're volitionally stopping and they have 4, 5 repetitions left in the tank, how many stimulating reps do they get? 1? Like, hardly anything. But if I give someone a set of 5, and I say, take your set of 5 to the point you can't do anymore, even someone who is really soft in the gym, they're going to take that to a point where maybe they could do 8 repetitions with it. Like, they're not going to use a 10 rep max. Like, they're going to, 7, 8. And so even if they're going soft and they're doing 5 with an 8 repetition max, they're still getting a few stimulating repetitions there. So in my head, there's just way less margin of error. If I'm giving someone low repetitions, even if you don't want to train hard, you're going to get maximum stimulating repetitions. So I think it's just psychologically, I think it makes sense.
Yeah. No, I understand. I think giving people sometimes more repetitions, it's making them like find out that they can push to failure. Like you said, on a pendulum,
Yeah.
if you put someone on a pendulum squat and they're used to doing 8 to 12 reps, and then you're like, no, we're going to do 3 more. That does then push them to failure. So I feel like sometimes you've got to find that out with the client or the person who's training first, and then be like, yeah, push yourself on 8 reps.
Yeah. Yeah. And I think as coaches, I think this is one of the most important things we can do is find ways, especially for online coaches. We need to find ways that we can actually help clients find what the limit actually is, because people don't know that. And it can be hard. So that's something I really enjoy, is trying to find methods that forces someone to find what the limit is. So for example, like I've got a training group at the moment where I'm using clusters with people. And I've got them to use a 6 repetition max, and they're doing classes. So they're only doing like 3 repetitions with that 6 rep max. But then that last set, just one set, they need to use that same weight, and they do an AMRAP set with it, as many repetitions as they can. And theoretically, it's a 6 repetition max. They should be getting 6 repetitions. Maybe they've got a little bit stronger. They should be able to do 7. But I'm getting clients who are doing 10, 12, 15 repetitions. And so now, like, that's a learning experience for them. Like, hey, that 6 rep max, it was actually a 12 repetition max and you didn't know it. And now they're seeing it and they're like, oh crap, well, I can't do that next week. I need to go up. And so it's forcing them to go up. But if we didn't do that and they just thought, well, that's my 6 rep max, I'll stick with that. Or maybe I'll add a kilo to it next week or whatever. They don't ever really see actually what they're capable of.
Yeah, 100%.
That's cool. Cool, mate. So next question by me is, so do you believe females should modulate the nutrition and or training around the menstrual cycle?
I think that
or is it person dependent?
Yeah, I think that there's some things that sound cool, and then you see like this stuff gets a lot of airtime on social media because it kind of sets coaches apart. I don't want to sound too condescending here, but I think that like I've had female clients who literally like they're hitting PBs during their menses week, right? Like they're killing it. I've had other clients where, they're lifting 20% less during that week. And I've had clients who maybe they've got, dysmenorrhea or endometriosis and they can't lift at all during that week. So it is really dependent on the client. If we were to just really generalize, we'd say, well, you should be strongest around ovulation. And so, because I did play with this years ago, I would do like a weekly undulating. I would give clients their strength work around ovulation. Then around the week of menses, I'd give them more like technique work. We would do high repetitions, maybe some speed work, whatever. And I didn't get better results. Like, it was okay. Some clients liked the variety, but I don't think they needed it. Now, I would say that in reality, 90% of females don't need to undulate their training. They're still going to be hitting PBs any week. Maybe they need to take a day or two off when they get the bleed, but that's it. But if you've got a client who maybe it's the week before the period or the week of the period, whatever week it is, it doesn't matter. If they know that they're not hitting PBs that week, they're going backwards. What are we achieving by going backwards? Okay, we're maybe not going to get smaller. We're not going to atrophy, but we're not moving forwards, right? And that I think we can't underestimate the psychological impact of some of that. So if I've got a client who I know for whatever reason, they're not going to progress at something. Have you heard of Charlie Francis? He was like a running coach, I don't know, years ago, I think it was like an Olympic running coach. But he used to say, like, I forget the context here, but if he had running athletes who it was an off day for them, like they were not going to be, they were like 100-meter sprinters. And it was like, this was not going to go their way. They weren't going to be hitting the right times. But he still wanted them doing that work, or they still wanted to be out there doing the work. He would make enough of a change that they couldn't compare their numbers. So it'd be like, okay, we're going to run up a hill, or we're going to run into the wind, or we're going to do something slightly different that you can't compare and you can't see that you're failing today. You know what I mean? So I think that psychological impact, like that's what I want to do with my clients, where I know you're not going to hit PBs this week. So do we change the stimulus? Do we change the exercises? What do we do differently here? So you're not going to look at those numbers and be like, oh man, this sucks. I'm so unmotivated. So that's where I think we should be changing it. Or like I said, if someone's got endometriosis or some kind of condition where, like a pain condition, then we need to be, I guess, mindful of that. But otherwise, generally speaking, most people, I don't think they need to alter it.
Yeah, I mean, like going back to your point, I see, because obviously with everybody's individual, aren't they? So
Yeah.
you see like different like PMS symptoms and different clients having different symptoms on different weeks, and it makes you realize how individual each female is that as well when you look more into the menstrual cycle and how they can recover, how they sleep, how the mood is and stuff like that. So for all the female listeners out there, kind of maybe track your own menstrual cycle and track your feelings, your mood, your hunger, your sleep around this and see how you train. And then you can kind of modulate your own based around your own symptoms then, I guess.
Exactly. Track your motivation, track how you actually do progress in the gym during that week. And if all that's looking good, why would you change it? But if you're going backwards or it's not working, then maybe pick something, a novel stimulus for that week, or change up the exercises, or do a slightly different rep than you would normally. Instead of doing 6s, maybe you do 8s to 10s for that week. I know I sort of spoke against that before, but this might be an opportunity to maybe do technique work, maybe you do clusters, like do something that's going to motivate you for that week, and that you're not feeling like, oh man, I'm weaker than I normally am.
It's one of them as well, mate. You could even just tell them to ditch maybe the logbook for that week and just kind of push to the amount that they feel like they can do that week, to just take away, like you said, that psychological stress of I'm not progressing.
You could. I think it will depend on the person. I know for me, even if I wasn't logging, I know what weight should be in the bar. And if there's less weight in the bar than there was in the past, like that's gonna mess with me. So I think it does depend on the person. But training depends on the person as well. Like some people just want to do the same thing for 12 weeks. They don't change it. I'm getting in the rhythm of it. Other people, oh my God, I have to do the same thing again. It's been 2 weeks, So I think people need to work out what's working for them.
Yeah, cool.
Sick. Another question, Jake, mate. So Nathan was touching on sleep then. What would you say to someone who's having poor quality sleep in a dieting phase, trying to lose body fat, in regards to cardio? So say, would you prescribe someone more sleep before you then give them more cardio? And why would that be?
So I'm assuming you're talking like steady state cardio, just like low intensity. We're not doing anything super high intensity here. Look, it's a good question. I think so. We have to acknowledge that there's good literature, some decent literature to show that sleep restriction, they call it. So this is like if someone's not sleeping, I think they compare like 5.5 hours of sleep a night compared to like 7.5 hours plus, something along those lines. And they show that those who are getting restricted sleep do lose more muscle mass and do lose less body fat. even though they might be losing similar amounts of weight. And, presumably there's an effect here around cortisol being catabolic and, potentially wasting muscle. There's other effects around fuel utilization and glucose and, carbohydrate utilization. So we have to acknowledge that, hey, most people aren't coming to you because they want to lose weight. Most people are coming to us because they want to lose fat. And they might think they want to lose weight, but it's like, okay, cut off an arm. You don't just want to lose weight. Like, you actually want to lose body fat. And not only do you want to lose body fat, you actually want to lose body fat percentage, and you want to maintain or build muscle. I've had clients in the past who are like, my only goal is to weigh this much. And I'm like, I don't think it is. I'm like, no, this is all I want. And they're like, I don't want to train. I don't want to build. I just want to weigh this. And I get into that body weight. I don't do this anymore. Like, I refuse to work someone they're not going to train in the gym because of this. I'll get them to the body weight. I'd be like, are you happy? Nah, I don't look the way I thought I was going to look. It's like, yeah, you don't look the way you thought you were going to look because you need the muscle there to give you the shape. So I think someone in that situation needs to understand, okay, maybe plausibly for some people, adding more cardio in might continue to help you lose body weight quicker, but is that actually going to get you to where you want to get? That's debatable. So I don't think that's a super clear answer to your question, but I think it depends on, is this once off? Like, people, as humans, we can deal with some stress, right? Like, that's sort of life. But if we're saying someone's literally getting like 4 hours of sleep a night, every night, they feel like, they feel awful in the morning, they're crashing in the middle of the day, is the priority there to get up an hour earlier and do your cardio? Probably not. In that instance, I would we've got two options as coaches, broadly speaking. We can get someone eating less, or we can get someone moving more. In that situation, if possible, I'd say, look, save your time, get more sleep. If possible, let's eat less, or let's have a couple of days a week where we're eating less. Let's make up for that just by eating less 2 days a week or whatever. But ultimately, if someone's getting 4 or 5 hours of sleep, then I would really want clients to be getting 7 hours or more.
Yeah, 100%. I think that's something that a couple of people who I've trained in the past can't seem to understand. They're just coming like, oh, I had no sleep, but it's fine. I'm going to push through this session. But that's probably making them worse off than actually just getting to bed early.
Yeah, it's that whole like, I sleep when I'm dead mentality. It's like,
yeah,
it looks hot on social media. Yeah, you look so tough, but it's like, you're not getting anywhere fast. That's not actually helping you achieve your goals.
Yeah, I think a social media point is good as well, because like so many people see like you've got to get up at 4 a.m., 5 a.m., but if you go to bed at 11 p.m. because that's when your shift ends, it's not good at all.
It's not feasible. Yeah.
No.
I think I heard you say this on another podcast, maybe, Jake, where you said that quote about it's the mentality of I'll sleep when I'm dead, but you'll die if you don't sleep.
Well, yeah, you'll get there a lot quicker. Absolutely, yeah.
You'll die quicker if you don't sleep. Cool, mate. So, next question by me is, so can you kind of just dive into, like, if somebody's got compromised gut health, like maybe whatever kind of gut dysfunction they may be dealing with, how this will affect fat loss and how will it also affect muscle gain?
So the muscle gain, largely I'll be looking at that inflammation kind of process we were talking about before. So that's going to affect the ability to use those muscle fibers or recruit them, engage them, and then that's going to affect the ability to, experience tension in those muscle fibers and hypertrophy them. So that's the main concern I would have there. Yes, it could be some piece there with like nutrient availability and stuff like that, but largely it's going to be the fatigue that I'm concerned about, or the inflammation that I'm concerned about. As far as ability just for body composition as a whole to change or body fat to change, this is one of those areas where I want to acknowledge that I'm speaking anecdotally from what I've seen as opposed to what we see in the literature. There's not a lot of good research on this. And obviously I'm not saying that just because someone has a gut issue that denies the laws of thermodynamics and therefore calories in, calories out doesn't matter. But there are other things that do influence these factors. And what I typically see, if we were to look at gut issues as a whole, like let's broadly say like IBS, because that's generally what people would associate with gut issues. The main cause of that is going to be a bacterial overgrowth. And then after that, we're probably going to see things like a fungal or yeast overgrowth. We'll see parasitic overgrowth. And then we'll see like gut inflammation more generally, what you would call leaky gut or intestinal permeability. They're going to be the main players there. Obviously, there can be other stuff going on, and there can be some psychological things and trauma can play into it. But those are the key players. So if we look at those, I guess, individually, if we look at the bacterial component, obviously the concern there is inflammation and nutrient availability. Is that going to affect someone's ability to lose body fat? Sometimes I would say, like, I wouldn't say that always it will. Yeah, I've certainly had clients who have SIBO, bacterial overgrowth, and they're able to still achieve body composition results and still lose body fat. But what it will do is it's going to, like I mentioned, affect nutrient availability. It's usually going to affect energy. It's usually, like, a lot of the time there's going to be, because we know that bacteria is producing not just those endotoxins I mentioned before, but things like lactic acid. Lactic acid is a metabolite you get from exercise as well. So it's kind of what makes your muscles feel heavy and sort of fatigued when you're doing the exercise. So these people, they're generally walking around feeling fatigued, right? So if you feel fatigued, you've got, maybe anemia, low B12, low iron, whatever else. What's your energy expenditure going to be like? Like, you're feeling awful. You're not going to be like, you'll notice that these people, they're not vibrant. They're not talking with their hands and expressive. Like, they're actually conserving energy. So that's the main issue sometimes with people with those issues going on, is like their energy expenditure is going to be compromised because of that. Now, I would say the same thing is with yeast and ultimately with leaky gut as well, that because they're also going to affect nutrient status. But with yeast, there's another issue going on in candida, fungal infections, and that issue is it's producing another toxin. It's called acetaldehyde, but basically it's the same toxin produced by alcohol. And so in this instance, you're actually compromising your ability to utilize carbohydrates and utilize other fuel sources, because essentially you're using basically alcohol, using acetaldehyde as a fuel source. You actually need to burn that. And in these clients, these are the ones I've anecdotally seen that seem to be the most fat loss resistant. And again, not all the time, not everyone, but these are the ones where they're on way lower calories than you would expect to take someone. And they're tracking perfectly, and they're doing 12,000 steps a day. They're doing everything perfectly, and nothing is budging. So those are the ones I do find quite challenging ultimately. Like, they are quite fat loss resistant, and you do have to get quite creative as a coach. And I do think obviously, the problem is people then assume, well, I'll just get rid of the fungal overgrowth and I'll drop weight. I wish I saw that. Sometimes you do, maybe 30% of the time you see that. But I'd say more often than not, what you see is you get rid of that issue, and now you're able to build that person up to a normal baseline. And then once you've done that, then you can get that body composition result. So it's not like it's not an 8-week deal and it's like, okay, sweet, I'm going to be shredded in 8 weeks. It's like, no, in 8 weeks from now, you're going to be able to get started. And then we might be able to refeed you and build you up and get you feeling better and burning more energy. And then we're going to do the fat loss bit. So it does make it a longer process. Things like parasites and H. pylori, I didn't mention it. H. pylori is like a bacteria in the stomach. Those two kind of they can go both ways. I've had clients with parasites, for example. There's one really common parasite, something called Blastocystis hominis. I've had two clients that I want to mention here. So one of them had blasto, and she went down to 1,100. She was a small person, but nonetheless, she went down to 1,100 calories. She was doing over 10,000 steps a day, training 4 days a week, tracking perfectly, could not budge any weight whatsoever. In fact, her weight went up, and I suspect it was just inflammation. She just wasn't recovering. Yeah. I had another client with blasto. She was competing in bikini. She was eating 32 or 3,300 calories, and she just could not gain weight. Couldn't gain weight for the life of her. We dealt with the blasto, and then she started gaining weight. She wanted to gain muscle, right? So she wanted to gain weight. We dealt with the blasto, and then she started bulking really successfully in like 2,700, 2,800 calories. So it can really go either way. So it is a tricky one. Same with H. pylori, that stomach bacteria I was talking about. So I've seen clients where they just can't gain weight. Like, they drop weight, lose muscle, they can't gain muscle. And then on the flip side, again, that can cause nutritional deficiencies, can cause anemias, can cause, low energy expenditure. I guess the best way to think about this would be the way you would think about the thyroid. Is people look at the thyroid and they say, well, I've got a suboptimal thyroid. I'm hypo, therefore I can't burn energy. I can't lose weight. And it's like, well, actually, we know that the effect that actually has on energy expenditure is really minimal. ultimately what's happening is you just feel awful. You're not going to get up and go for a walk. You're not going to, want to do like clean up around the house and get up and go to the gym. And like ultimately your body is just stopping you from actually using energy. And that's why you're not losing weight. So, we're not blaming the person saying you're being lazy, but your body's not wanting you to actually do anything. So I think with gut issues, generally it's coming back to that kind of mentality of ultimately, like, you feel like crap. You got all these waste products in your body. You're like literally a full detox burden that you just feel like you're made out of lead. You're inflamed. You're struggling to perform well in the gym because you're training too much. It's a recipe to not get anywhere.
So basically, it's a fatigue and energy issue that's causing somebody to not do the fundamentals that they need to do, basically.
To an extent, like they may still be doing the fundamentals. They may still be getting up and forcing themselves to walk, right? So, we're obviously familiar with NEAT, non-exercise activity thermogenesis. So this is the energy you're burning when you're not exercising. And I think coaches have made this mistake for a long time. They used to say, well, NEAT is how many steps you do. So I'm just going to program you 10,000 steps. I'm going to get your NEAT levels up. That's not NEAT. That's literally programmed exercise. So NEAT is the exercise you're doing when you're not doing your 10,000 steps and when you're not in the gym. And that's the thing that's compromised. And how do you change that? How do you tell someone, hey, I want you to fidget when you're sitting. I want you to talk louder. They don't control that. These are subconscious things. So that's the thing being affected usually. It's like, mate, you just competed. Like, how did you feel the week before you competed? Were you hot and like taking off your jumper and jumping up about the place and wanting to go and burn energy? Or were you like, did you have a hoodie on and you're cold and you're just sitting there not doing anything?
Yeah, mate. I mean, like, I definitely wasn't as upbeat as I am now on this call, put it that way. Yeah, cool. Dale, next question, Matt.
Yeah, so going back into training, get a lot of beginners and a lot of people in the gym saying that they feel like free weights are going to help them build more muscle than cables or machines. I'm just thinking if you could dive a bit deeper on why cables and machines are so important.
Yeah, so someone can build an amazing physique just using dumbbells and barbells, absolutely. But you have to be more intelligent with what you do. And I think that I'm guilty of, I prioritize or I like barbells and dumbbells. I like the classic lifts. But first we need to acknowledge there's nothing special about using a barbell, right? Because what's the logic people would claim here? They would say, well, when you're using a barbell and you're not using machine, you're not using a cable, you have to stabilize that weight, right? Like there's not a fixed bar path, and so you're having to use all these stabilizers, and therefore you're getting this extra muscle recruitment, and that's helping. And ultimately, what we know is there's only so much of a signal you can send to a muscle, right? Like imagine you've got 10 power points and you've got 10 different things plugged into those power points. It's like we're dispersing that electrical signal across 10 different things. But if we could just plug one thing in, we can send that entire signal to one thing. That's what we can do with a machine. We take out all these co-activists, all these muscles that are having to stabilize the joint and work to kind of keep everything safe. And we can just send that whole message to that one muscle we actually want to stimulate. So what I'd say is for a beginner, using barbells and stuff, it's like, well, yeah, you might actually be, yes, this stabilize muscles and I think to my point a second ago, we don't want to focus on that, but you may be using more sort of muscle groups in one go. If we look at something like a bench press, okay, you're going to be using your pecs and you're going to use your shoulders, you're going to use your triceps. So if it's someone like a beginner, you're probably getting a little bit more bang for buck using a machine, using an exercise like that. But by the time you're more intermediate to advanced, we talked about the stimulating repetitions model before. Well, a beginner, because they're having grown the triceps, all the pecs, all the shoulders, when they're doing that bench, they're getting probably 5 stimulating repetitions for each of those muscles. But now you get someone who's advanced, and there's going to be a muscle which is failing first in that lift. So if I do bench, for me, I actually think it is actually more my chest. But for a lot of people, it's usually going to be more delts, more triceps. And so let's say, like in my instance, my chest is what's limiting me. Okay, I take a set to failure. I might get 5 stimulating repetitions for my chest, but how many did I get for my delts? How many did I get for my triceps? Like 1, 2. Like it's gonna be significantly fewer than what I got for that one limiting muscle. So Then you get someone who's doing bench thinking, oh, I'm stimulating, my delts and my pecs and my tris and I'm getting all this work. No, you're getting probably stimulatory work for one muscle. You could be getting the same amount of stimulation just doing a machine chest press or doing a cable fly or something like that. And then we go back to that thing I was talking about before, perception of effort. And how much more, like someone who's deadlifting, God, how fatiguing is it to go and load all these freaking 20-kilo plates onto the bar and offload them and rack it? Like that effort of loading and unloading exercises, I think we can't underestimate that. So you get someone who's advanced, who's lifting in good load, who's just using barbell and dumbbell exercises to get the same amount of stimulatory work in. That session might take them 2 hours, but you get them using machines where it takes 15 seconds to set it up and go. That same amount of work might take them 45 minutes. So even if we don't look at the fact, then we need to look at, well, how do we actually, we're limited by gravity when we're using barbells and dumbbells, right? So how are we going to hit maybe we want to grow our brachioradialis in our elbow flexor. So we're not trying to just hit the biceps brachii. We're actually trying to hit sort of that bit that's below the elbow. And that we know is going to be stimulated above 90 degrees. So when you bend your arm halfway, it's going to be when the peak force is above that. Now, that's not the way gravity works. Gravity is going to make the peak force at 90 degrees. So how do I now get a more force against the action of gravity if I'm not using a cable or I'm not using a machine? Now we have to get super creative. I'm going to have to lie face down in a bench, and I'm going to have to set the angle up perfectly. Maybe I use a band to be able to load it so that the band's making it hard in that top point. So you can still do these things, but the more advanced you become, you need to be really specific and really careful how you do that. So dumbbells, barbells, wonderful, but there's time limitations and there's limitations for actually stimulating the muscle you want to, the more advanced you become, just due to gravity.
Yeah, I think you've touched on that perfectly. I think you get a lot of people who, I don't know, maybe they've watched Arnold's Pumping Iron and they think they need to use dumbbells and barbells to grow. But like you said, if you've got a training split where you're doing, most commonly you'll see push, pull, legs, bro split, and they're smashing squats, bench press, deadlift. They're just going to completely knacker the muscles that they don't want to be.
Yeah. You could take someone who'd never been in the gym before, only give them machines and cables, and that's not going to be a limiting factor. Like you could literally just use isolation exercises, never use any compounds, and you're going to be able to grow. Like arguably, you could make it even a better physique. Like there's not going to be any downside of that. It's going to take you longer, like in terms of the sessions are going to take longer, but that's it.
Yeah.
And that's only as a beginner. The more advanced you become, it's not going to take you longer then.
Yeah, 100%.
Cool, mate. Last question by me, and I think, Dill, have you got one more?
One last on you.
Yeah, cool. So we've got last question each, and then we'll quick fire through the questions on Instagram. There's not actually that many. Cool. So my last question, mate, is touching on prescription pharmaceutical medicines effects on the human body. So can you explain the effects of PPIs, antacids that they have for the human taking these, and we'll dive a bit more deeper into that. I'll probably ask a few more questions off the back of it.
Yeah, cool. So obviously there's a whole stack of different pharmaceuticals people are commonly taking. One really common one would be PPIs. So these are proton pump inhibitors. Basically, you've got different cells in the stomach. Some of these cells, what their job is to make stomach acid. They also make something called intrinsic factor. And what that is I guess you could call it a transporter for B12. So it latches onto B12 and it helps the B12 be absorbed through the small intestine. So when we're taking a proton pump inhibitor, because someone's getting acid reflux or something like that, firstly, we need to look at the fact that, well, acid reflux is not always or or not even most commonly caused by high acid. It's caused often just by the acid ending up where it shouldn't be ending up, because we've got these valves that are on the top and the bottom of our stomach, and maybe they're not functioning properly. And a lot of the time that could be due to fermentation going on or putrefaction happening in the stomach, and potentially even low stomach acid. But that's besides the point. If you're taking these PPIs, it's going to inhibit these cells that are producing acid. So that may, in the short term, help those symptoms. It's probably not helping the underlying cause, but it may help the symptoms. But what's happening when you're inhibiting stomach acid and you're inhibiting intrinsic factor? We know that now you're going to be far more susceptible to B12 deficiency. We know that we need stomach acid for uncoupling and digestion of animal proteins. So that's stuff that contains the most bioavailable form of iron, zinc, other B vitamins. So now we're running into issues now with ultimately this nutrient absorption. So even before we look at the fact that it's probably making the issue worse, we're at a serious chance now of developing these nutritional deficiencies, especially B12. That's the key one I'd be most concerned by. But then we look at, well, what do you need B12 for? Well, we need it for the synthesis of DNA and RNA. We need it to make cells. We need it to not become anemic. We need it for neurotransmitters. We need it for liver detoxification. Like, it's a pretty important thing. Skin, nails, this is going to have a pretty big impact. So that's my concern with that. And this is why, honestly, even a doctor should be saying this is a short-term solution, right? Like, you can't do this long-term because you're going to get deficiencies. But sometimes you get clients who are like, yeah, I've been taking it for 5 years. Like, man, look at your bloods.
Yeah. Cool, mate. Well, just a point upon that as well. Like, obviously, there's other things that I feel like the general population could do with knowing a bit more about in terms of like harming the gut. And a couple that I've got wrote down here are like artificial sweeteners and pesticides. So could you give us your take on how these affect if they do or if they don't?
So, like I mentioned before, with the gut issues and body comp. So anytime the stuff that I don't think is really well solidified in the scientific literature, I do just want to acknowledge that. I think that this is one of those areas where it's a little bit early days. And I do think that we can have an evidence-based opinion on it, which would justify what I'm about to say. But I do want to acknowledge that we are somewhat limited in the research we have. But we do have evidence that have come. So let's use, obviously, when we're talking about artificial sweeteners, there's a lot of different artificial sweeteners, right? But if we talk about sucralose, well, we know that we said this was safe based on the fact that it didn't biotransform in a human, right? So basically, it did not change its form into a different, more toxic substance. So we said it was safe, but now we know it does do that and actually becomes significantly more toxic. So that's a concern. We also said it was safe because it doesn't accumulate, but now we know it does accumulate, right? So now it's like, well, that we predicated saying that there were safety limits here based on these things that aren't true. We also said that it didn't cause any damage, but we know that that substance that it converts into actually seems to damage DNA. So that's another concern. There's some evidence now to suggest that it could actually compromise or cause inflammation within the gut. So this is I guess I would say like an early stage of research, but I think there's enough compelling stuff coming out around its effect around DNA, its effect on gut inflammation, its effect on bioaccumulating within the body, that it makes sense to me we would want to limit it. Now, a lot of people notice that they develop or they have food sensitivities to it anyway. There's certainly a lot of, I guess, like conditions that have been associated with some of these. I don't want to say food allergy per se, like it's not an immunoglobulin allergy, but for all intents and purposes, it is an allergy. And people have experienced symptomatic relief when they have cut out those foods. So it's certainly something that I think for some people will have a really significant impact. It's something that, like, in all honesty, for me, if there was a food that I wanted to eat once off that had artificial sweeteners in it, I'm not going to be concerned once off, right? But for example, there was a pre-workout I was taking that had artificial sweeteners in it. I'm like, well, I didn't realize it had that in there when I bought it. I'm not going to buy that again. I got to want to have this daily, but if I'm exposed to it every now and then, I don't think it's going to be the end of the world.
Yeah. Cool, mate. Awesome.
Last question.
Pesticides. Let me quickly touch on that. I forgot.
Yeah,
Almost
go on.
forgot.
Yeah, go on.
So I would say that's in a similar boat as well. So if we look at, the main one we'll talk about is, well, I don't want to take too long here, but if you look at the way pesticide and toxicity sort of reports are done, what they say is they look at the most active compound, and then that's the one they measure. So you could actually have pesticides or be using some kind of commercial pesticide that has, let's say, 10 different active ingredients, all of which could be toxic to humans. And they're going to look at the one that is in the most abundant and most abundant in that formula. So they're not actually looking at the total impact of everything that's being used. So that's a massive red flag in and of itself. Like, that makes no sense. But even if we look at the ones that are most commonly being used, the most common one people will know will be glyphosate. Glyphosate seems to mimic glycine, which is an amino acid. So firstly, they say, well, glyphosate's safe because it works off this something called sugarmate pathway, which doesn't affect humans. It only affects bacteria. And it's like, okay, that's all well and good, but like, we're mostly bacteria, right? So, okay, it's not affecting our cells, but it's affecting the bacterial cells within us, which are kind of making up us. So that's still an issue in and of itself. But even if that wasn't the only issue, it seems to mimic glycine. So there seems to be, there is some concern that what could happen is what you would call protein misfolding. So protein is just a sequence of different amino acids put together in a chain. And what could happen is that glyphosate could essentially misplace glycine in that protein. And glycine is one of the most important amino acids when it comes to collagen. Why that matters is the gut lining is made out of collagen. So it's very, very plausible. And it seems that there's some research to support this. However, it's heavily challenged and pushed back upon by forces that be. But there's some evidence to suggest that we could be misfolding glyphosate into essentially like intestinal tissue proteins. And that could be causing a really significant problem. And we know that there's actually mechanisms for this exact same thing in nature. Like we've seen there's natural compounds in nature that mimic other amino acids and are misfolded into proteins instead of that amino acid. So we know that this mechanism exists. Again, it seems that there's some research that would support this, but it is not financially lucrative for that information to be shared.
Cool, mate. Awesome. I've learned a couple of things there.
Same here. Last question from me. If you could recommend one supplement for the general population, what would it be and why?
I'm going to cheat. I'm going to say an electrolyte supplement, because a good electrolyte supplement will cover, hopefully, both magnesium and potassium.
Yeah.
And if we look at potassium, so I think magnesium is probably the more important one there.
Yeah.
And we know we need magnesium for literally every single metabolic process in the body, right? So if people have magnesium issues, they're likely going to have blood sugar issues. We know that magnesium interacts with adrenal hormones and cortisol. So magnesium can help with sleep quality. It can help, we talked about cortisol and the effect on body composition. It can help with, blood sugar management, metabolic issues. It can help with pain scores. There's so many things magnesium can help with. So I think, and we know that people are not consuming anywhere near as much magnesium as we used to. If we look at Paleolithic times, this is the guess, I suppose, is that we were consuming, I think it's something like 3 to 4 times more magnesium than what we're consuming now. Now, our needs haven't really gone down. We're just not consuming anywhere near as much of it. So that's a big concern. And then if we look at people in the gym who, most of your listeners are in the gym, well, one hard training session can heavily deplete magnesium. Like, it can deplete hundreds of milligrams of magnesium. So anyone listening to this who's in the gym, they really should be supplementing with magnesium. But then potassium, if you look at actually the literature, I guess, on potassium intake, it suggests that, at least in American stats, between about 98 to 99% of people aren't consuming enough dietary potassium. And I would say that those recommendations are actually lower than they should be anyway. So arguably, every single person listening to this is probably not getting enough potassium. So if we could combine those two, I think they're two of the most overlooked or under-consumed nutrients that we need. And you know what do we need potassium for? Well, we literally need it for muscle contractions for starters. For a lot of people, it can enhance sleep quality, it'll lower blood pressure. A lot of people will notice like cognitive benefits with it. If we have low potassium, we're going to experience issues with digestion, with constipation. So these things can be causing a lot of issues if we're not conscious of getting enough in. So a good quality electrolyte supplement, that's one 90+% of people will benefit from.
Yeah, perfect. Thank you.
Cool, mate. Well, so we've got some quick fire questions. We'll try and make these as quick as possible because we're actually well over time. So I do apologize.
No, that was my bad. I couldn't stop myself with some of those questions.
Cool, mate. So first question is by KM Coach. So he's asked, did I mess up my ability to absorb from more foods by eating chicken and rice for 5 years, 3 to 4 times a day?
Most likely no, but the concern there is obviously if we're exposed to the same protein over and over and over again, and we have gut inflammation or permeability going on, we can develop food sensitivities. So that's the main concern. Other things like enzymes we need for other foods that he may have been excluding, those things come back online relatively quickly. So you start introducing some of those foods back in, we'll start to upregulate enzymatic processes or secretions. So that shouldn't be a huge issue. But if someone's been eating like a super limited diet for a long time, you would introduce some of those foods in small quantities and let yourself build up over time.
Cool. So next question. So she's kind of asked two. I'll condense it into one. So Nick Keane has asked, my gastro doctor has prescribed me amitriptyline and pura calcipride. Does that make sense to you?
Yeah, so that's a prokinetic, and the other one, there's a few different, it's a atypical, it sort of works on neurotransmitters.
Yeah, cool. So she's asked, is this a helpful med or am I being fobbed off? And the puricalcipride made her sick, so she couldn't take it.
Okay, I'm not sure in what way it made her sick. It's a prokinetic aid. So I use Iberogast. Iberogast, you use this as well. Iberogast works very similarly, and in studies, it's been shown to be about as effective. It does a very similar thing. So a prokinetic aid is just going to help basically it's going to help all the muscles in your gut kind of contract and work together and push everything down. It's not a laxative, but it's just getting everything moving. Now, if she said it made her sick, it's plausible it could have caused something like diarrhea. That is possible. It's not super likely, at least not with Iberogast. I'm not sure there's different side effects or likelihood there. But as a prokinetic, I would say that maybe 50+% of people with digestive symptoms of IBS will benefit from a prokinetic. Especially that bacterial stuff we were talking about before. We know that a leading cause of that is issues with that sort of system pushing everything down. It's called the migrating motor complex. Now, if that's not helping her, it's not helping her, right? So obviously, when we can't say don't follow your doctor's advice, but if I was in that situation and it was making me feel worse, I wouldn't be taking it. The other compound that she's using, other pharmaceutical she's using, that's working on manipulating neurotransmitter levels, and that sometimes can help as well. But again, sometimes it won't. Usually, my understanding there is it would actually have more of an effect if someone is more prone to loose stools. Now, again,
just one sec. She did say that one was for her IBS, the amitriptyline.
Yeah. I assume both of them would have been. And because you can also be prescribed for like depression and anxiety. So in her instance, my understanding, and she may want to double check this, but my understanding is it's the goal there is to regulate serotonin levels, and serotonin is obviously the master regulator of essentially, I guess you could say, motility in the gut. And we know that people with digestive issues. So there was actually a study done. I don't know if you saw this. I think I shared it not long ago, where they had people with IBS follow a low FODMAP diet, and there are people with IBS follow a low FODMAP and a low tryptophan diet. Tryptophan converts into serotonin. The people who followed a low serotonin, effectively FODMAP diet, they actually had a far greater improvement in reduction of loose stools and diarrhea than those who just did the low FODMAP diet. So we do know manipulating serotonin can have an effect. But again, that's not going to be for everyone. It's really going to be mostly for people with loose stools. Now, to answer your question there, are either of those a solution? Not really. They can help symptoms. They can significantly help symptoms. But if there is a bacterial overgrowth there already, they're not going to get rid of that. So I would say, look, you probably need more than that. You're going to need more support than that. And you're going to probably need more sort of direct, I guess, quote unquote, treatment than that as well. But they are also not the worst medications you could be taking to try to get symptomatic relief. But it sounds like, unfortunately, they're not providing that for her.
Yeah, cool. Right, so we got 3 more questions. So, are stool sample tests testing specific bacteria and parasites worth it and legit? That's by Sam, SME Coaching.
What's the last bit of that? Are they testing specific parasites and bacteria?
Are they worth it, and are they
worth it?
Are they legit?
So,
worth it?
Yeah, so there's different ways of doing that, different types of stool testing. Broadly speaking, there's something called CDSA, and then there's PCR. I much prefer PCR. That's looking at the genetic sort of fingerprint of the bacteria and the parasites, where CDSA is trying to culture stuff in a dish and see what's there. And there's a lot of stuff that can be missed with that. So do they measure what they're meant to measure? Yes. Are they 100% accurate? No. You take the same sample, send it to 2 different labs, you're going to get 2 somewhat different results, but I would say there's going to be enough unison there that you can still use that information. But for me, I couldn't use that information without a blood test. So a blood test, if we look at a picture, a blood test is going to give me 70% of that picture. Your symptoms are going to give me 25%, and then something like that stool test would give me 5 or 10%. So by itself, I don't think you could confidently or I don't think you could really make a treatment plan based off that alone, but it can give you clues.
Yeah, cool. So same person's asked another question. He's actually asked 3 questions. So Sam's asked, is the Mediterranean diet style diet actually the best for gut health?
No, it's not the best for gut health, but it is really good in the literature around things like fatty liver disease. That's probably one of the main ones it performs super, super well. Now, it really broadly speaking for gut health, let's say someone had gut issues, then what I'd say is there's 2 pathways you can go down to help improve those symptoms, not fix them, improve them. One is, are your symptoms caused or exacerbated by FODMAPs, right? If they are, it's probably suggesting you've got a bacterial issue. You still want to address that, but following a lower FODMAP diet is going to help. If FODMAPs don't make it better or don't improve the symptoms, then I would try a paleo style diet, which still has FODMAPs in it, but it's just removing obviously mostly processed foods. And there's a couple other things that it's taking out, some certain types of carbohydrates and starches. And if you feel better following that, it's most likely your symptoms are more driven by inflammation as opposed to bacteria. That's kind of the broad sort of 2 pathways I go down. You could go a little bit further with the paleo diet and do something like an autoimmune paleo diet or carnivore diet. And that would be like the most extreme elimination diet you would do to help with inflammation or autoimmunity. But from a symptom management point for gut health, they're the ways I would go. From a maintenance standpoint for gut health, that's a really broad question. I would say a animal-centric diet with, where possible, organic fruit, stuff like honey, fermented foods, good quality dairy. I think that style diet, I can't see any shortcomings with that diet. Is a Mediterranean diet problematic? Well, I would prefer to have, like, red meat's certainly more nutrient dense or micronutrient dense. So I think that there's some shortcomings there, but a Mediterranean style diet in general, like there's certainly much worse diets than that. I don't think that's hugely problematic, but I think we could do a little bit better.
Cool. Last question by Sam. Is senna and magnesium citrate okay to take long term if gut motility is an issue?
Magnesium citrate is a little bit more gentle. Senna is really more of a laxative. Um, I'm not super concerned. My biggest concern is if someone's constipated. So if this is stopping you from being constipated, that is better to me than you being constipated, because that's a really quick way to develop a bacterial overgrowth. That said, if you are using these things and it is speeding up motility a little bit quicker than it should be, you might be losing some nutrients. You could be losing some electrolytes. So I would be conscious of potentially, taking more electrolytes. But the other thing I would mention in this case is what happens if Sam did use a prokinetic, did use something like iberogast. Ginger is another natural option you could use. It's not quite as potent. But if you use something like a prokinetic, like iberogast, you may find you can stop the center, you may be able to reduce magnesium citrate, or maybe you just, need a 200 milligrams of magnesium citrate or something with it. That would be my preferred option. But if someone needed something like Senna and mag citrate to not be constipated, I would prefer they did that than they go back to being constipated.
Cool. Well, that's all my questions. Dill, did you get any from people?
Done. No, I've got no questions.
Cool. Well, that's it, Jake. So I hope everybody's learned something. I know I have, definitely, from what Jake's just been talking about. I know it's kind of a bit of a broad spectrum of all different avenues, which was quite cool.
Yeah.
Thank you for coming on, Jake. Really, really thank you for giving up your time. I do appreciate it, mate.
Absolute pleasure. It was fun, guys. Like I said, I apologize for talking too long. I know some of those answers are long-winded, but hopefully some of your listeners stayed with us till the end.
Yeah. Cool. Have you got anything you want to shout out, mate? Your Instagram or anything like that?
Yeah, I mean, if people want to find me, then Insta's the place to go. So Coach_Jake Doleschal. You actually said my name right when you introduced me, so thank you for that. Most people don't get it. So that's Doleschal if people want to find me. But that's really all I've got to share.
Cool, mate. Well, for those of you who've listened to the end, thank you for listening. Like, share, and subscribe this podcast. I'm _transcend. We've got Dylan_transcend.
_transcend. Yeah.
So thank you for listening, and we'll see you all on the next episode. Thank you.